Good morning, everyone. It is really my privilege to moderate this first panel of the day, and not to make the panelists nervous, but we are live streaming, and I really want to thank them for sharing with us their best thoughts about what can Medicaid redesign efforts of states, what can Affordable Care Act really offer the promise of children, and in particular why I care so much about this panel is I have the privilege of directing the McSilver Institute for Poverty Policy and Research. And so kids that are poverty impacted, their families who are trying to raise them, they are the families that potentially are going to benefit from some of the redesign efforts, but also they are the families that at least historically have sometimes been left behind by our system. So my hope is that this panel will give us some ideas about how best to serve young people, their families, with some of the tools that are available through federal legislation and the supports that we have. And so I'm looking forward very much to a discussion. Our panelists brought a set of key slides that I hope they'll make available to us in their entirety, and they really are knowledgeable. So I hope we can come up with some provocative questions, some difficult, challenging questions for us all. So without further ado, I believe, Lisa, you'll be first. Oh, the district. Okay, so go ahead.
I think it's me.
Go ahead. Heather, please. Thank you.
Welcome to all of you, and I just want to, for full disclosure, I said this to Charles, I am not a social worker. However, my middle child of 6 is a social worker, so I have some creds being here with you all because of him.
That's great.
It's delightful to talk about early periodic screening, diagnosis, and treatment, which is a Medicaid program which is voluntary for families and obligatory for states. Every state that has Medicaid, and they all do, are required to have an early periodic screening, diagnosis, and treatment program, but families do not have to participate if they choose not to. Most families, first of all, don't know that, and second of all, most families want to participate because it provides for children who are, as Dr. McKay said, impacted by poverty, the same kinds of screens and interventions that children who have regular commercial insurance have had access to for years and years and years. And that, I think, was the thought of the legislators when they developed EPSDT, was to make sure that kids impacted by poverty had the same access to good quality preventive, early interventive health care, and their families could be provided with anticipatory guidance through this program. The anticipatory guidance is called Bright Futures. If you don't know about it, look it up on the web. It's fascinating because it does provide a lot of help to families on parenting and raising their children. The agenda for today will be, first of all, to talk about the Medicaid benefit for children, which is EPSDT, and as Colleen has instructed me, it's now the Medicaid benefit for children because nobody gets this vegetable soup, and after 30 years, we still don't get it. So Medicaid benefit for children. We're going to talk about children's health coverage in the district, which we've already acknowledged is quite phenomenal. EPSDT in DC is the integration of primary care and behavioral health care, which is an initiative that DC has just started and is working very hard on. And then the system of care, which has already been mentioned, and Dixon, which has been settled. So early, this is kind of a busy slide, but I want to get it all on one. The issue that we talk about with children is to identify their problems or their emerging issues early on. Because as you know, if you identify them early and you treat them early, you have a far better result. The health check, the EPSDT is known as health check in the district, provides periodic age-appropriate screenings of children to identify any problems, both physical problems and behavioral health problems that might be arising in their development. A large part of that, as I mentioned, is to provide families of young children with anticipatory guidance so that they know what to expect developmentally for the next stage in the child's life, how they can interact with their child positively. They deal with things sort of tangentially of discipline, which is a big issue, on providing structure for children, and it helps, I think, the parent and the provider, whether they be a pediatrician or another healthcare provider, to bond over these issues of raising kids and what a challenge it can be. The screening is conducted of the whole child, and one interesting sort of Medicaid historical note was that the feds realized at some point that children were getting screened and having a physical, but they never took their clothes off. So if there were anything that the physician needed to check to see if there were any skin eruptions, any bruises, or anything like that, the pediatrician didn't know. So my mom was a pediatrician, and I remember her coming home and telling me that the kids had to get unclothed. And she said, you know, I've been trying to do that for a long time. It works with little kids, but with adolescents, forget it. They're not going to take their clothes off. But it is a requirement that the screening be done in an unclothed physical. So diagnosis comes from identifying those issues which need treatment. Diagnosis is something that we need to work on, I think, with behavioral health and pediatricians and physicians. And I think collectively we can make an enormous difference in how early kids are identified and then what happens to them afterwards. Treatment is mandatory for any risk factor that's found during any one of the EPSDT Medicaid Children's Program health check visits. So treatment is required to ameliorate the effects of any one of those risk issues. States must perform data analysis and report to the federal government on an annual basis of how well their providers, which in the district are mainly managed care companies, are doing with adhering to the periodicity schedule. Did it do anything? No. Okay, somebody, there we go. Who's the next? Huh? It's the next one. So this is just the access, okay. So one of the major efforts of the Medicaid agency in each state is to inform families that they have access to these services and access to well child care. It's something that, you know, I've lived long enough to remember the days before Medicaid, when people generally, I'm a native Washingtonian, was born at Garfield Hospital, when mainly people got their health care either from a community physician who was a family practice doc that was living in the community and generally had their office downstairs and their home upstairs, or they got care at the emergency room. Obviously, that's not adequate care either for children or adults. So access is a really critical issue, and also helping families understand the need for taking their children and themselves regularly to get well child and well adult care. It's a process of what we call health literacy, and it's an ongoing process, and it is critical that we do a really good job of that because for all the reasons we've talked about previously. The screenings can happen during a visit to the doctor for a cold or for something else like measles if they happen to have those measles or some other illness. A physician or healthcare provider can do a screening then that's outside of the periodicity schedule if they see that there's something that they need to check out. It's perfectly acceptable and it's reimbursable. The other issue, of course, is this health education and counseling to parents at whatever connection there is between the healthcare provider and the family member. When the treatment is available easily, families tend to access it. One of the issues that we know is with families who are stressed because of economic issues, housing issues, other issues, taking their child to a therapy session halfway across town is not something that families can do easily. So one of the things we need to really be aware of is making access real, making it based where families can get to it, where there is transportation. Medicaid does pay for transportation to treatment, but it's getting families organized around doing that. And that's part of what we do as anticipatory guidance, is talk to the families about how are we, this needs to happen. This child needs to have whatever it is, vision check or a hearing check or physical therapy or whatever. How are we going to get there? How are we going to make these appointments? Because one of the things that happens sometimes with families is that they break appointments, and then doctors don't want to see them, and that vicious cycle starts. And we can prevent it by working with the families to help them organize around actually getting to the treatment. Medicaid actually covers almost all treatment that children need. And in fact, there is a part of the statute which requires states to pay for treatments that aren't explicitly in the state plan, which is what we call our Bible. It's our guidance. It's our policies and procedures. It's what the federal government has said we can do with our program and the services we can provide and to whom. And so one of the things that we have found is that in some states, evidence-based practices, before they've become part of the Medicaid plan, state plan, have been sort of done on a pilot program through this exception under EPSDT. Just a thought. So you can take that, yeah. Oh.
So I think that these next two slides really just amplify what Heather has been saying about the screening and the diagnosis and treatment parts of EPSDT. So I think I'm going to skip these two slides to get to children's coverage in the District of Columbia. And good morning, everyone. I'm Colleen Sinoski with the Department of Healthcare Finance also, and run the Division of Children's Health Services, which oversees the EPSDT benefit. And as Dr. Barron referenced and has been referenced before, we are doing really well in the district in terms of health coverage for children, from children who either have employer-sponsored coverage or public insurance through the Medicaid and CHIP programs. We are in, one of the top states in the nation, usually right behind Massachusetts, which has a health reform law passed, Vermont, which also has a universal health reform passed. So we are doing very well with probably insuring about 96 to 97% of our children. And a lot of the work that we've been doing on the data end at the Medicaid agency has been to get a clearer picture of the percentage of those children who are insured, who are covered by the Medicaid program. And that is a pretty high number, too. Depending on how you cut the numbers, it can kind of run anywhere from 70 to 80%. So Medicaid covers an awful lot of children in the District of Columbia. Of the Medicaid enrollees in the entire program, about 40% of them are children. And again, we have many ways of making sure children are eligible, either through their income, through disability status, through being wards of the state. So there are a number of pathways into the Medicaid program. And the district, a long time ago after the Children's Health Insurance Program was passed, chose to use CHIP dollars to expand the Medicaid program. So that's why we go up to about 300% of the federal poverty level, which is one of the reasons we do cover so many children and families. So, with that, even though CHIP obviously pays for many children in the district, we really think about it that all children are Medicaid children, and they all receive the EPSDT benefit. All Medicaid rules apply. Everything is focused from really the Medicaid side. And as Heather mentioned, one of the reporting that we have to do to the federal government is on a form called the CMS 416. And in FY12, we reported about 97,000 children were enrolled in Medicaid at some point during the fiscal year 2012. And again, EPSDT goes up to a child's 21st birthday. So it's through the age of 20. It's up to 21, where they would then transition into continued Medicaid coverage or other coverage. And in the district, children are enrolled in both the fee-for-service program, but primarily in managed care, which I will get into in a few minutes. I think one of the things that we wanted to talk about in this session was the impact of healthcare reform on children's coverage. And because the district is already is one of the leading states in the nation on children's coverage, the coverage points of health reform don't really apply all that much to the district. We have many of our children insured. The Urban Institute puts out data every year on Medicaid and CHIP participation, and we are also in the top on that. We, in FY 2010, we enrolled 97% of those eligible to be enrolled. In FY11, it went down a bit, but it was in terms of thinking about numbers, we still are in the top 5 of states in the country to have Medicaid and CHIP participation rates very, very high. We're at about 95% now. So for those reasons, we really focus a lot on what's the service delivery and what is the system, and that's a lot of what Marie and I are going to be talking about. In DC, EPSDT is branded as Health Check, and I admit I continually call it EPSDT, so I'm not doing all that well on the branding part, but for our providers and for many of our families, they do know of the benefit as Health Check. And as Heather discussed, making sure that everyone has access to these services, whether it's transportation, scheduling assistance, having an access helpline for both dental and behavioral health services, having language interpreters, are all something that we continually work on in the district to improve those services and make sure, number one, that they're known and that people have the ability to use them. A large part of our Medicaid program is through managed care organizations, and currently we have 4 Medicaid managed care organizations that serve about 90% of the children in the district. We just started a new contract year in July and actually did a lot of work to improve children's health services and children's mental health services in coordination to make it clear to the managed care organizations what the government's expectations are of them, so we know how we can hold them accountable and have a focus on children's health. So a number of the sections of the contract had a big focus on children's mental health. And one thing that we are working on in relation to behavioral health is what I call the integration of primary care with behavioral health and developmental health. So EPSDT is a great benefit where we have our children enrolled with managed care programs. They have a primary care provider. They have a schedule of when they're supposed to be seeing their providers. The providers have different screens and different tests that they're supposed to be doing during all of those visits. But part of the challenge of government is being able to know how we're holding that accountable and being able to have the data to tell the story of what is happening with our population. So a large part of this initiative right now is to really get at that data. And for a Medicaid agency, the way we get data is through claims of what we pay for. And part of the claims goes to, as Dr. Barron made a mention to this, what code is used. So I'm a lawyer, so I tend not to think about codes. I just tend to think that these things need to be done. And so getting to the point of knowing what codes need to be included and the Department of Healthcare Finance and the Department of Behavioral Health having the appropriate data to know how our children are being served is a real goal for this year. And so making those instructions clearer and having regular reports from the Medicaid agency side is something that we are working on. With that, a rollout will happen with providers, and we have I would say, pretty unique online training tool for our providers, primarily the pediatric primary care providers. So this wouldn't really affect kind of the specialty providers or psychiatrists, but it is a good start with making sure that the primary care providers know what they're supposed to do in these well child visits. And I put the website up on the screen because it's a site that is intended for providers, but we are hoping that it is also a site that is good for families, for government agencies, and for as well as just the general public to have an understanding of what is going on in the district. And another activity that we're doing is one of our major MCOs is hosting a summit next month on the integration between primary care and behavioral health care that we hope will bring a lot of providers together, community folks together, MCOs together, MCO folks together, and government together to really talk about how to begin this conversation and bring about change. And then all of this is also being done in collaboration with the Department of Behavioral Health, and our mental health agency just changed its name, so I'm still getting used to saying that, but I think I got it down. So the coordination of this integration effort is a real partnership between the Department of Behavioral Health and the Department of Healthcare Finance. So to make sure that government agencies are working together and have the same goals is also something that's really important, but is happening in the district. And so a collaborative of Department of Behavioral Health, Department of Healthcare Finance, as well as other providers and Children's National Medical Center, we have a group called the DC Collaborative for Mental Health and Pediatric Primary Care, where we are really looking at the selection and adoption of specific mental health screening tools, and part of then the rollout of how we train our primary care providers will flow from that. And part of that will also be through a learning collaborative with our providers and the Children's National Medical Center, and then other efforts underway in the district that we are trying to make sure all have the same goals, whether it's developmental or whether it's through different grants, that we are bringing them together to make sure that we're working towards the same end. So I think that's primarily what I have to say, and I think all of those other things like System of Care and Project Launch are what Marie is going to talk about. There you go. Thank you.
Good morning. My name is Marie Morales Black, and I'm the State Mental Health, Children and Adolescent Director for the District of Columbia. I have 49 other colleagues 50 other colleagues in the country. And we do have actually monthly meetings where we talk about what's happening across the country in children's mental health. And one of the things that I'm excited to talk about is the fact that DC in the last few years have really improved its children's behavioral health, that now we are really one of the leaders in the country in some of the continuum of care that we've developed and the number of children that we're serving in the community. We received a grant from SAMHSA, and part of the grant was to really look at how do we expand our system of care. And the framework for that, I think, Mr. Del Vecchio in his presentation and Mr. Barron talked about it, is that we're really looking at a collaborative model. And system of care really talks about the family, a family-centered approach to delivering services, and that the child and the family is in the center, and all of those different components are really worked around the family to make sure that the family's needs and their behavioral health is really being addressed. I want to share that since 2009, we have increased the number of children that we are serving in the community. We, in 2009, were serving about 3,500 plus kids, and now in 2012, the last data, we're looking at over 4,000 young people. Now, the public mental health system in DC really serves the highest end of young people. So it's that 5 percentile of young people that really needs the service is who we serve in the district. Colleen mentioned earlier regarding the managed care. They are primarily responsible for the outpatient delivery of kids in the community. And once the children need some in-home or intensive services, the behavioral health department really steps in and provides services for those young people. The other thing I also want to say is that since 2009, we have added an array of evidence-based services into the district, and they are listed there: multisystemic therapy, which is an in-home service that works with the family and the child; parent-child interaction therapy is an outpatient; functional family therapy is also an in-home intensive, it's family-centered. We have trauma-focused cognitive behavior therapy, which you heard Mr. Del Vecchio spoke about the trauma and the stats on 1 in 4 children in the country have suffered some kind of trauma. This is a trauma, as well as the next one, which is child-parent psychotherapy. They're both trauma. One is for kids, the CPP is for kids under 8, and the trauma-focused cognitive behavior therapy can go up to 18. So as you can see, we also have wraparound services, and those services, and I'll talk a little bit more about those, is to really provide high-end, community-based, facilitating, case management type of services for those families that really need some extra support and need someone to help them manage the different systems that their lives are being participating in. And then lastly, there's a huge need for us to focus on the kids, young people that are between the age of 16 and 24. One of the things that the Affordable Care Act has done is that it increased the coverage of young people under their families. And I have to say my son, who's 24, is a beneficiary of that, along with many other families in the country, which really supports the transitional age youth in receiving behavioral health services in this country, because often young people dropped off their parents at a critical age when they need transitional support, particularly those that are impacted by behavioral health, and through the Affordable Care Act, allow them to have continuous coverage so that there is no disruption of their care post-21. So that's one of the, and of course, personally, I'm benefiting from that as well. So I'm very excited about that piece of the act. The other piece that we do in prevention is providing school-based, and Barbara Parks, the administrator for our children's division, will be talking about that immediately after lunch, so I won't spend a whole lot of time talking about some of those, but we touch a lot of students. We've had a lot of referrals. And during the intervention that I mentioned below, we touch over 8,000 plus young people in the school district. In the district, we are doing a two-prong approach because we believe through early periodic screens, as well as the fact that 88% of of adults that have persistent and serious mental illness were diagnosed as a child. And you saw the stat earlier in regards to the number of young people that are diagnosed before the age of 14 and deal with trauma even before the age of 4. And so, having said that, we are looking at two-pronged approach in the Department of Behavioral Health. And let me pause here to say, we are the Department of Behavioral Health instead of Department of Mental Health because we have merged effective October 1st with the Substance Use Department. So we are a combined agency now so that we can really deliver integrated care for those impacted by mental health as well as substance use disorder. So that's why our name changed. It's because we're now one agency. So the two-pronged approach is really to develop early intervention, which is our kids under 8, and to provide services to them, as well as managing those that have onset of behavior and diagnosed mental illness, to provide those services to them as well. And I'm not gonna spend a whole lot of time going to all the different services because these slides will be made available to you. But I wanna quickly go through them. Primary project is also a school-based, and it's for kids between pre-K and second grade, and I'm sure Barbara will go into more details on that this afternoon, that we provide so we can help our young people to, that are having adjustment issues in schools, identify them early, and then provide it quickly. We also have Healthy Futures, and that is a mental health consultation model that we provide, and that service is in our child care centers. We have social workers that are providing consultation to teachers in the child care. So if the child start having biting issues or behavior problems, et cetera, so that instead of saying the child is bad, right, and to really then reinforce the negative behaviors, we really are teaching the teachers on how to refocus, provide support, and change the behavioral trajectory for that child so that they become, we promote positive social and emotional development so that those young people can not get labeled and that the behavioral difficulties that they're experiencing can be resolved earlier. Then for those that absolutely need some support, we have the Early Childhood Treatment Center at Howard Road and at one of our provider community in the DBH DC community called Mary Center. And those two providers provide parent-child interaction therapy, which is one of the evidence-based practices that I talked about, and they also provide play therapy, art therapy, to help change the behavioral discussions for those kids. And let me pause here to say, we had a little person, he was 6, and he was being threatened to kick out of kindergarten. And because he was throwing chairs, he was living with his grandma, he was ripping blinds out of the windows of the school when he got upset, and grandma had to often, almost on a daily basis, was getting calls that he needed to come and she needed to come and sit with him or pick him up. And he and grandma went to parent-child interaction therapy, and after 8 months of intervention where they learned how to do timeout, how to refocus the behavioral, and this parent, grandma, is one of our champions now because this young person not only changed their behavior, but within 8 months of being in school, he was no longer suspended, grandma is no longer getting called, and he became the attendance monitor, where he had gotten well enough and behaved well enough that he was being allowed to take the attendance to the office. So treatment, when catch early, can work. And now grandma is one of our champions for this service and is training with us on parents to engage them on how to do the work. We also provide services for families, moms that are dealing with postpartum depression. We are providing currently services to about 70-plus women and their infants, and you all know what happened in DC just a few weeks ago in regards to the woman that was killed. And if the media reports alleged that she had postpartum depression, it's real. We do get referrals from our health centers to that, and we provide in-home as well as outpatient. And then we provide ongoing services to moms with their children up to 2 years old, and that's our Healthy Start program. And then we are the envy of the rest of the country, DC, because we have a psychiatric practice group that the government operates, and it provides urgent psychiatric care where people can get same-day psychiatric services for emergencies. So someone can call our Howard Road practice group. We have 3 full-time psychiatrists that works for it. And they can say, we're having a child in crisis, we need the child to be seen, and we can see that child within 24 hours or that same day, if necessary. And my colleagues around the country, other state mental health directors, are very jealous because none of them have such a service that DC. And so part of this process is really getting the word out to let folks know that we have this kind of continuum of care within the district and that people can really access those wonderful services that we offer. Part of the reason we've developed this continuum is to prevent young people from leaving our community and going into residential treatment, and it's working. In 2009, we had over 240-something young people leaving the district to go to psychiatric residential inpatient services, and now, today, we're down to 61. So we still have more to do, but we're excited about where we're going. And wraparound services that I mentioned earlier contributes to that. We can't talk about behavioral health without talking about juvenile justice. And one of the things that we did with the Superior Court is to really develop a way for those young people that have mental health issues that the reason they are connected with JJ, juvenile justice, is because of their impulsive and inappropriate behavior. So when we identify those young people, we work with the OAG, the defense attorneys, and the court to really provide a diversion program that we call the juvenile diversion program, so that if they participate in treatment, complete treatment successfully, that there is a possibility that their case may be dismissed or they do this sentence suspended because they are now staying out of trouble, they're being safe from the community, they are not getting rearrested because they're addressing their treatment needs. And we're excited that we've had some really, this program is just beginning its 3rd year. We've had some wonderful outcome in regards to the number. We have reduced recidivism. It's 60% around the country. In DC, it's 30. We still have some ways to go, but we are looking to improve the outcome for that. And one of the final things I want to say is that we are working to develop all of those, and it starts with screening. And the behavioral health component is to really look at having social and emotional developmental screening at WellCheck, so that behavioral health becomes part of the normative process of going to the doctor. Because the same way that we do eye check, my child gets a height, we want part of behavioral, social and emotional development to also be what pediatricians do. And that's what Colleen was talking about, and we are piloting with the pediatricians in the community to roll this out. And we're hoping that through normalizing social and emotional development positively, that, as Mr. Del Vecchio mentioned in his speech, when children go to see a counselor, it's normal. It's like going to the nurse. There's no bullying that happens around that, and there's no teasing that happens around that. That's where we're trying to go. And with everyone really looking at positive behavior and that mental health matters, and it's important to care about your mental well-being, that we will eventually reduce the stigma in mental health. Thank you.
Hi, thank you. I'm very excited to be here and to represent and explain and share my experiences as a direct clinical social worker. So many of the models and evidence-based practices that we've been mentioned today, I'm actually trained in and have the privilege and challenge of working directly with families to implement and to actually provide the services that we've been discussing here today. So I do have a little disclaimer. So I gained a great deal of experience and training at the Child Study Center at Yale, but I recently resigned and will still be in the New Haven area, which is actually federally been designated as a high needs and underserved area and population. But I will be across town at Integrated Wellness Group, which is more of a grassroots community mental health organization that has a holistic approach and interdisciplinary model to serving these high needs families. So again, many of the evidence-based programs that we have discussed today, I've been a part of. So multisystemic therapy, I did that for 2 years, and also trained in trauma-focused CBT, very familiar with PCIT as well. Again, my voice here today is really about my personal experiences as a provider and also with the families that we serve, regardless of my affiliation. So, thank you. The bottom line is that from my experience and observations that without Medicaid, many of these highest needs children just flat out would not receive the services. It's an imperfect delivery model, and we're all working, and that's why we're here today, to improve it. But without it, these children just would not have it. There is no other access. There is no other means or for them to receive it. And I've seen firsthand how powerful it can be to complete a trauma-focused model, or even in a more open-ended psychotherapy approach, or working with parents, because although the client is identified as the child, you can't do child and adolescent-focused work without being involved very intimately with the family, with the parents. If the parent isn't able to get the child to the clinic, then they're not getting the service. Again, my experience primarily is with MST in a community-based model, but also in an outpatient setting. So it is the service that, yes, it is there and available, but it is them coming to us as providers. And that doesn't always fit the bill. It doesn't always work, and there's a lot of barriers to that for a lot of our families. So Medicaid provides transportation, but then the questions come up of, well, do you live on a bus line? So therefore, here's this alternative mode, and that doesn't work for families for a variety of reasons. The families that we serve in the clinics I've worked in have been approximately 90% Medicaid populations, is that it's not black and white. Clinical work is really challenging, and it has 1,000 shades of gray. So I think some of the concerns as we expand, which is wonderful, because again, without the expansion, there wouldn't be the service, is as we go towards evidence-based practices, which is kind of the wave across the board, which is, again, extremely beneficial because I've seen it firsthand work. But I think there's a concern from clinicians of what does that look like, and how, is our reimbursement going to then be called into question, and, what does that mean for the clinics we work in, and that, are the barriers to services and what's going on for families really being taken into consideration, and does, just because we only got to step 2 of a model, what does that outcome then going to be measured as a failure? And the reality, from at least my opinion as a clinician, is no, that although the families might have been able to, or not have been able to finish the model to its entirety, they didn't, that doesn't mean that they didn't have a benefit to it, or that the seed wasn't planted for then being able to access the services, and to seek the services at a later date. The social work is about meeting people where they're at. Sometimes that usually is referred to emotionally and kind of where they are, but sometimes also physically. And we have to be able to think of that and the policies that we're making within a social work framework, because the families we serve have an extraordinary amount of psychosocial stressors that they are facing. I know, particularly in New Haven, that community violence and trauma, not only trauma to the child, but multi-generational trauma and poverty that are all coming into play as we're trying to provide the services to the best of our ability. And that is not without challenges. So even for families that are, already qualified and receiving services through Medicaid, I often see, we didn't know we were temporarily removed from our services because we missed a paperwork, or we didn't get that notice because, we've moved 3 times in the last 7, 8, 12 months. So I think these are all challenges that we have to be thinking about, and that policy needs to be considering that, like I said, there's all shades of gray, and we really need to be able to, yes, have accountability and fidelity to evidence-based models that work, but we also need flexibility as clinicians, because I don't think, and for the sake of families, because it is really challenging work to be in a room with a family that is struggling and having all of these difficulties, and that added stress of, did I check the right CPT code, and did I, what is the outcomes going to be? Because sometimes it really feels like an unnecessary additional stress to what is already a very stressful job, rewarding, very much so. But I think that's something we need to be mindful of, because as we expand access, we also need the workforce to provide the services. And if without qualified people who are trained in these models and in the quality ideas of social work and other providers, psychiatry, psychology, without them, we won't be able to serve the families that need it the most. I think, unfortunately, I've often heard my colleagues say, I will, it's, this is good, and I'm really getting the training I need, and this is exciting, but I'm really looking forward to going into private practice when I can, because this is just too much as far as some of the regulations that come along with Medicaid. And I've certainly, and I'll admit, have thought that before too, because it is so challenging. And it's hard to worry about and take on the burden of the thought of what's going on in the room for the family, and then also be mindful of, I need you to sign this, and within this certain date and this certain time frame. And that's a lot for clinicians to carry. I don't know any social workers or other providers that really went into this excited about paperwork or excited. And I think we really need to be mindful of that to maintain a quality workforce, because if you spend a lot of time training people in really great models and then they decide to leave for private practice or leave for a different field, then where does that leave us as being able to provide the service? So I think those are kind of my thoughts on things to consider as we discuss this policy. Thank you.
Thank you, Lisa. Thank you. So I so appreciate listening to the people to my left. These are people that have devoted their life to making sure that kid services, kid systems really are supporting some of the most vulnerable kids and families. And so I also know that the audience in front of me hasn't had some opportunity to ask a question or make a comment yet. And so I'm going to open up the floor first to those of you that I know have listened really attentively, to ask some of our panelists some questions, and I'll try to repeat, or they will try to repeat, so that we can actually get the questions in the video as well. So are there questions from the audience?
I think it's a really important point that was brought up by Ms. Casagnola about Medicaid paperwork. When I was an MST therapist, I loved my job. I loved working with families in the district at such an intensive level that you are involved in all these different systems. You're involved with the educational team. You're involved with the medical team. You're involved with other mental health providers. You're involved with the juvenile justice system. I was highly involved in the JBDP multiple times on multiple cases. And there's a lot of great services out there, but the primary reason that contributed to my overwhelm as an MST therapist and why I ultimately left that job was the paperwork. I mean, particularly for a specialized provider such as MST, I mean, anyone in here knows how much paperwork we have to do to bill Medicaid. Multiply that by about 50, and that was being an MST provider. The turnaround times, because you're working so intensively with families for paperwork, is often 24 hours or 72 hours. I mean, it was astronomical. It was overwhelming. And so much of the focus in working in that organization was paperwork, paperwork, paperwork. And you really lose sight of the clinical work. I never personally lost sight of my clinical work. That was my priority in my job. But all those regulations and all that paperwork have to be done. And for me personally, that's what just, really made me not be able to stay in that particular position anymore. And it was sad because I really felt that we did a lot of positive work, and I really commend the district on the focus on collaboration between different agencies and different providers, because that needs to be there. My next question, I guess, would be, encountering when working in schools in the district and also in working with different providers as an MST therapist, there's a serious lack of empathy and compassion even among certain providers that are working, not social workers, I'm biased, but just in general, certain teachers, case managers, community support workers, oftentimes probation officers, oftentimes you encounter many of these providers who really do not truly believe that mental illness is a contributing factor to the issues going on with these children. And I just would like to know, with the district's plan to have this collaboration and this focus on how mental illness contributes to so many issues with children in society, how can social workers help to educate probation officers better, police officers better who are encountering these children out on the streets committing crimes, teachers in the classrooms. I mean, in DCPS, it's optional if a school even wants to have a school social worker, if they feel like it's worth it to have it in their budget. And that's oftentimes just the, independent opinion of a principal. DMH mental health therapists in schools is an amazing program here in the district. That's expanded, but is that going to be put into more schools? I just would like to know how social workers can, in the district, help to educate all these different fields and really lead the effort to have everyone collaborate around youth mental health in the district.
Thank you. Thank you.
And thank you for asking those questions, and I'll pay you later, because this gives me an opportunity to talk a little bit about some of what we're doing. I don't know if you all remember last year, or is it 2 years ago, South Capitol? Remember in the district, 4 young people were killed on South Capitol Street. And as a result, there was an act enacted by Councilman Catania. It's the South Capitol Behavioral Health Act. And as a result of that act, DBH, the Department of Behavioral Health, have several deliverables under that act. Now, not that we weren't planning to do it anyway, but as you know, when things become law, it expedites the timeline. And so as a result of that act, the act is required for us to expand school-based mental health, that wonderful school that you just talked about. This year, in my budget, was $1.9 million to add school mental health clinicians to 19 new schools. We are using some of those dollars to also, remember, we talked about the two-prong approach, to also increase the primary project, which looks at doing interventions for pre-K to second grade, so we can catch those kids earlier. That's also being expanded this year. In addition to that, part of that act is to provide for every single teacher in the public school system within the DCPS and charter school, Mental Health 101. And what we are currently doing is developing a webinar that's interactive so that teachers can be educated and understand behavioral health issues and how it impacts young people in their classrooms. And we will be tracking that every teacher, that's part of our deliverables, is data, so that we'll know that teachers actually receive that. There will be some in-person training as well as webinar. To support that, we are in the process of releasing on our request for proposal to have a comprehensive resource, electronic resource guide, as well as a physical or hard copy resource guide that's also part of this bill that's happening this year, this fiscal year, to have on the web a real live in vivo access to how do you refer, what to do next, and who to refer. So we are in the process of doing that. Currently, we are in the midst of disseminating youth mental health first aid. You heard Mr. Delvecchio and Mr. Barron talk about that, and that's really to teach recreation centers within the district, community at large, about mental health. And so that people understand that it's not because the child really doesn't want to do it, it's because they really have an issue. We're also training people on trauma. We have brain scan that shows the difference between a child brain with trauma and a child brain without, so people can see. Because sometimes I think behavioral health, you can't see it, like, diabetes or cancer. And so I think sometimes people think they're just bad and they just don't want to do it. So educating the community around that. So we currently have 15 trainers on youth mental health first aid to do community outreach and to provide service. And part of the grant that I mentioned earlier that SANSA gave us also has a social marketing component. And then to wrap up real quick, last year we did a busting stigma at one of the charter schools as part of our children's mental health first aid. We already planning for next May, mental health first aid, Children Mental Health Awareness Day. And then 2 weeks ago, on Saturday the 12th, we had a community conversation about mental health on creating solution. And that's when we brought business people, young people, and professionals, and community people. And we had around 400 and plus people to have those discussions. So all those things is to exactly do what you just said, to help people to start having the discussion around mental health and to educate the community and to help them to begin to reduce and be more empathetic around the illness.